But now why I was emphasizing on the follow-up component was because this child can develop some complications also. One of the very important complications that is asked in multiple choice questions and has been taught both in dermatology and at this moment I am teaching also is dermatitis herpetiformis. So you will have encountered these questions talking about extraintestinal manifestation of these patients. The leading one is dermatitis herpetiformis. Most of the time, the child will be developing pruritic vesicles on the elbows and on the knees. I'll show you the image also, but I just want you to remember that just like you are comfortable with the fact that Gottron papules are always found on the knuckles. Gottron papules were discussed in dermatomyositis. Gottron papules are always found on the knuckles. I want you to remember if they anytime give you an image of vesicles which are present on the elbow and the highly pruritic child keeps on scratching, so there would be excoriation also. Please appreciate in scabies, the scratching would occur in all over the body, right? Especially over the axilla, over the groin area, between the finger clefts of the person. But in this case, I'm mainly talking about vesicles, which are gonna be itchy on the elbows and on the knees of the patient. Once the image comes in, you will be able to relate to this better. But first, theory is obviously important. So they can sometimes give you a spot diagnosis also. If they give a history of celiac sprue, obviously it's a piece of cake for you. Then you don't need to refer to the image also. But if they do not give the image or cut, but if they give the image alone without mentioning dermatitis herpetiformis, even then you should be able to correct the question. In fact, we will also be going in for diagnosis of dermatitis herpetiformis in two ways. One, I can go for antibody that will help in diagnosis. Second is obviously a biopsy of the skin with immunofluorescence study. When it comes to the antibody, the name of this antibody is anti-ETG antibody, that is anti-epidermal transglutaminase antibody. You see, it might look very easy for you at the moment, but I've seen people mess up between these antibody names in the final pressure in the exam. There are two names that I've told you today. One is double TG, that is tissue transglutaminase antibody, and currently the name that I'm telling you is ETG, that is epidermal transglutaminase antibody. Along with this, the biopsy report will also come. So most of the time you will be biopsy reports with immunofluorescence will always be green. And you will be able to see a breach in the basement membrane, and then there would be lots of immune complex depositions. These immune complex depositions are mainly of immunoglobulin A and the complement. So like in the earlier parts of our discussion, we have talked about fishnet appearance with respect to pemphigus vulgaris. I am today highlighting the fact that if you get a green line which is broken at multiple places with these dots which are greenish in color, again representing immunoglobulin A and C3 deposits, your diagnosis would be what we are discussing right now. I want to emphasize, if he begins with celiac sprue, this will not be any trouble for you. So I want you to have a capacity where even if celiac sprue is not given in the question, the history of malabsorption is not given in the question, spot on, you should be able to identify that the patient's lesion is dermatitis herpetiformis, and this is how it will look. The question will mention vesicles on the elbows. You can see the vesicles which are pruritic. So you can notice lots of erythema present which are present on the knee joint of the patient. and then is this green line I was talking about, and this shows that spotty appearance. That spots are basically the IgA and the C3 deposits. Additional aspects which are to be remembered for this topic would be, and that's bad news for the parents, that you would tell that I think that your child may, obviously I'm not saying always, may develop type 1 diabetes. Here I can put up a question to you guys just to keep your interest going. Can you tell me the cutoff for diagnosis of diabetes mellitus in children? Adults, we know HbA1c more than 6.5%. Suppose it's a 10, 12-year-old child. You're suspecting he might be having type 1 diabetes because it's associated with celiac flu. What is the cutoff HbA1c? The answer is still 6.5%. Similarly, the fasting values of 126, 2-hour values of 200. The cutoffs useful for diagnosis of pediatric diabetes and adult diabetes are same. The next statement is even the way more important. In fact, this is the last paragraph of celiac flu topic in Harrison, and that is from where he has created the question. You see, these kids can also be having chances of development of GI cancer, and the GI cancer that develops is not adenocarcinoma, it is lymphoma of the gut. In fact, why is it so important? The point number 3 that I've written is, if he says what is the most common cause of death in celiac flu, then do not answer malabsorption, malnutrition, electrolyte imbalance, because diarrhea is occurring, so electrolyte imbalance. Do not answer any of the earlier statements that I said. The number 1 cause of death in celiac flu is gonna be answered by you as malignancy. Most guys have a habit of answering things like malabsorption and associations of diarrhea like electrolyte imbalance, but the answer to this question is what I've just highlighted, and this is actually the last paragraph of this particular topic. So lots of time, when we read a topic, we tend to focus more in the initial part. It's just that you need to maintain consistency when you're reading a topic, when you're listening to a lecture, right from the beginning to the end. Your concentration has to be spot on. And I have highlighted this time and again that if you are going to listen to this repeatedly, then the chances of your ability to retain this information will be relatively higher. The next topic I'm going to explain to you is tropical flu, which will be explaining regarding adult patient. The number 1 reason why this can happen is primarily because of coliforms. And in the coliforms, the predominant one is E. coli. In some books, he will also mention regarding Giardia, but if both are given in questions and they ask for a single best response, your answer happens to be E. coli. Now, what is this coliforms gonna do? You see, I'm not talking about E. coli based diarrhea just once. It is repeatedly occurring, so this might be a relatively low socioeconomic strata person, or for that matter of fact, a person from Western country who's come to India and is a low budget traveler. Now this guy is gonna stay in cheap hotels. He might be eating street food in India, and Americans, once they eat street food in India, they really gonna get sick and they might be having multiple episodes of E. coli diarrhea. So the end result is that if you have a recurrent E. coli infection of the gut, especially due to street food consumption, then this person will be having mucosal gut injury, and the bad news is then the osmotic diarrhea component can definitely set in. Apart from this, it has been documented that this condition can contribute to impairment of gut motility also. Now, when I say the fact that gut motility is lesser, most doctors, they send me a message saying that, sir, if you're saying gut motility is lesser, will it not cause constipation? You see, I'm not saying that gut motility is going to be reduced to the level that it's going to cause a constipation. All I'm saying is that the peristaltic waves are not occurring in the gut the way they should. So what is the problem if gut motility is slightly reduced? The osmotic load, you see, whatever solid food that you've eaten, carbohydrate basically contains sugar. So whatever that you have eaten, that will remain in the gut for longer duration. No? I want to emphasize the fact that if gut motility is significantly hampered, obviously then constipation will occur. Here there's a slight reduction in the gut motility. The end result is that the osmotic contents remain in the intestine for relatively longer duration, and therefore because they're remaining in the gut for longer duration, they can draw more water, and once they draw more water, the stool will be softer. That's what I meant by the word osmotic diarrhea occurring in the patient. I want to highlight this statement because usually I get a lot of queries saying that, sir, you said decreased gut motility, why is it not gonna be constipation? It's a slight reduction. So the end result is again a osmotic diarrhea component coming up. Let us now talk about the clinical features that will be occurring in this patient. He will begin by describing adult, or he might be a traveler from a foreign country who's having these problems at the moment. The primary complaints is osmotic diarrhea. Now, because this makes diagnosis relatively easier and you are able to understand it's something related to malabsorption, so you have to select from those options. So he might be just using some terminologies just to, I would say, waste your time, like bloating or borboigamy, or abdominal fullness, or just abdominal discomfort occurring in this person. There would be a weight loss occurring because you see carbohydrates constitute an important source of nutrition. If carbohydrates are not absorbed, so the caloric component absorbed from the gut on a daily basis reduces. That's why I said weight loss occurring in this guy. Also occurring will be steatorrhea. This will cause bulky, greasy, foul-smelling stools, and concomitant with that would be deficiency of vitamin A, D, E, and K. Now, I want to highlight that when it comes to vitamin K deficiency, there might be features like purpuras. Meaning of the word purpura would be palpable bleed in the skin. Vitamin D deficiency will contribute to bone pain. Vitamin A deficiency can contribute to night blindness or nyctalopia. I'm leaving one for you guys. Can you tell me manifestations of vitamin E deficiency? One of the manifestations of vitamin E deficiency is neurological feature that can come up. And that would be answered by you as ataxia. Another feature of vitamin E deficiency is RBC surface or RBC membrane will be appearing to have spikes. So the RBCs that are seen with vitamin E deficiency are called as acanthocytes. So there is a distinct possibility that because in this condition the levels of these fat soluble vitamins will be lesser. Therefore, either in the general physical examination or maybe in the workup of this patient, he might talk about terms like acanthocytes in a workup or purpura in general physical examination. Because B complex group of vitamins can also be affected. You see, after all, it's a mucosal disease, no? So even water soluble vitamins, the levels can definitely reduce. This will give him opportunity to describe terms like stomatitis or chiliosis or gingivitis. So most of the time I will find that Doctors do not have difficulty in identifying this disease per se because the manifestations are relatively very characteristic. Muscle weakness will also occur in these patients subsequently. The reason why myalgia or muscle weakness is described is due to electrolyte imbalance, because he is having these loose motions on a recurrent basis. Every time he eats food, he needs to go to the washroom. I have discussed irritable bowel syndrome separately, so I hope you are understanding that in irritable bowel syndrome, person might be having bloating. There might be abdominal distension, but when he will go to the washroom, he might be having passage of stool. After that, there will be relief of symptoms of the patient. But in this case, the manifestations will persist. These patients will be having recurrent episodes of loose motions. And in fact, even if we study what irritable bowel syndrome, where diarrhea is mainly a symptom, the total amount of stool passed is usually less than 200 ml. I have discussed that in IBS, guys, but I'm highlighting that in irritable bowel syndrome, person will go to washroom again and again. Even if he is saying diarrhea, no, the volume of stool is not much. But in this case, the volume of stool can definitely be substantial. So there can be electrolyte imbalance that can come in. So there can be electrolyte component that can come in. That would be hypokalemia. Apart from this, he can also talk about proteins not being absorbed in this person. So because of hypoalbuminemia occurring in these patients, they could be development of puffy eyes or periorbital edema. Now I need to do a workup of this patient. The best way to confirm the diagnosis would be a small intestinal mucosal biopsy. This will again be showing a blunting of the villi. I don't need to repeat it once again, unlike in celiac's proof where we had to repeat it at least twice. I would just like to summarize what I have highlighted at the moment for this particular topic before we talk about the treatment part. He says that you need to demonstrate at least 2 product malabsorption. Like, what I mean by 2 product malabsorption is like carbohydrate malabsorption and then fat malabsorption. At least 2 products malabsorption has to be demonstrated in a person. Like if I'm not having access to a biopsy or person is refusing, I can do a breath hydrogen test and a breath triolein test. No, breath hydrogen test is for carbohydrate malabsorption. Breath triolein test is for fat malabsorption. So 2 product malabsorption must be demonstrated with ideally biopsy findings. That way you are sure about the fact that you are dealing with a tropical sprue in a person. If it's a foreign patient, like American patient, or let me say English person coming over to India, so he's gone back to America and now he's having these diarrhea manifestations. So if in his case file it is mentioned that there is a history of travel to a third world, that is countries like India, Sri Lanka, etc. So history of travel to developing countries and then development of diarrhea subsequently after eating a street food is again a very good hint towards diagnosis of tropical sprue. Let us now look at what is the treatment for this condition. So your primary antibiotic that you're gonna write for this guy is tetracycline. Along with this, because jejunum is mainly affected, therefore folic acid supplementation would be done in this case. Unlike in celiac's proof where I was giving iron plus folic acid, here we are primarily giving folic acid because it has been demonstrated that it is jejunum that is worst affected in this condition. The next topic that I'm going to explain to you is called as Whipple's disease. This would be caused by a intracellular bacteria with a slightly tongue-twisting name, that is Trophairma whippleri. You see, I've explained to you regarding extracellular bacteria, that is Helicobacter pylori, but this is going to be intracellular and it's going to be found in the macrophages of the gut. So we need to use more aggressive treatment for this because it's relatively more invasive organism. Let's look at the manifestations that are caused here. The question will again describe an adult person with muscle wasting. He will talk about weight loss in an individual. So the manifestations are same as that of tropical sprue. I can just bring that slide to your notice once again. I mean, what is the information that would be given? It would be standard information related to carbohydrate malabsorption and fat malabsorption. Now there are some additional pointers also that I want to highlight, but this is going to be the initial profile of the question. You see, because there's also weight loss occurring in a person, there's a protein deficiency occurring in a person, so there's a distinct possibility that he might, even in some questions in journal physical examination especially, he would write a feature of protein deficiency. You see, whenever there's gonna be a significant protein deficiency, like even in kwashiorkor in pediatrics, when there's a substantial protein deficiency, you will read about presence of cellophane skin. Cellophane paper, right? It's very thin, parchment-like paper. The skin has become very thin, parchment-like. So cellophane skin again highlights protein deficiency in the body, which would be secondary to the muscle wasting component that would come up in all of these diseases because the nutritional supply is definitely hampered. Now, what are some special pointers that will be given in the question which will tell you that this is Whipple's disease? Would be some CNS and cardiovascular manifestations. If you read about features of malabsorption plus development of dementia, you see, very shocking, no? Young age person with malabsorption syndrome with dementia manifestations. He might even mention some neurological features like nystagmus, even might mention seizures in a patient. So the surprising thing is that a combination of malabsorption syndrome with CNS manifestations or even cardiovascular manifestation might be occurring in this person in the form of aortic valve disease. These 2 pointers will always ensure that the question is going to be the topic that we're discussing. For diagnosis, I will be doing a small intestinal mucosal biopsy, and then we will use a special stain called as PAS or is called as Schiff's reagent. Small intestinal mucosal biopsy has a high diagnostic yield in this case. Most of the time, the multiple choice question will himself describe all these findings, that is of a PAS positive intracellular bacteria. And why am I highlighting this statement is, guys, because I need in IV antibiotics, because you see the infection is so deep-seated in the gut. It is in the security system. These bacteria are sitting in the macrophages. So devised a method of bypassing the security system. That I would say it's relatively a deep-seated infection occurring in the gut. PAS positive intracellular bacteria. Now a related terminology I can mention here for alpha-1 antitrypsin deficiency, because there also you read about PAS positive inclusions in the hepatocytes. I want to tell that in alpha-1 antitrypsin deficiency, you have defective alpha-1 antitrypsin, which is defective in a sense that it is not produced. It is produced, but it is not excreted. So it keeps on accumulating in the hepatocytes and hepatocytes are damaged. So whenever you read the term PAS positive inclusions in hepatocytes, That is when you need to think in terms of alpha-1 antitrypsin deficiency, which is also associated with emphysema. But in this case, I use the term pus-positive intracellular bacteria, which are gonna be located in the macrophages of the gut. Now I can just zoom in the image, which is showing so many inclusions. These are obviously a very high power view, which you can see in the gut, where these inclusions are found inside the security system. Now we will have to use a more aggression for management of this case. So initial antibiotic that is given is ceftriaxone. Normally we read about ceftriaxone for bacterial meningitis, no, because third generation Spalosporins is when we are talking about infection of the meninges. But a gut infection where we're giving ceftriaxone, apart from typhoid, right? Drug of choice for typhoid nowadays is ceftriaxone. And I mean, it can vary from country to country. In India, mostly ceftriaxone is used. The second time in GI, when you start with ceftriaxone to be given, is Whipple's disease. And here, unlike in typhoid, you will give treatment for 7 days, maybe 10 days, max 14 days. But here, you will again have to give at least ceftriaxone for 2 weeks. And that's not the end of the story, because the infection is deep-seated in this case. You will also have to give oral cotrimoxazole. So there are two antibiotics that are used in this case. First ceftriaxone, then cotrimoxazole. And the duration of cotrimoxazole is a huge 6 months. I want you to remember the details which are highlighted here, especially the CNS and the serious manifestations will be given in the question, and they are obviously a time wasting tactic by the examiner, because if you can just pick up it's a malabsorption syndrome in adults, either it's gonna be tropical sprue or it's gonna be Whipple's disease. So if you can pick up the clinical pointers in the question, you definitely have cracked the question. I mean, even if you don't know how to evaluate the histopathology image, like lots of guys will say, sir, I cannot even pick up that this is GI. I mean, it's a high power view. So if I'm not a pathologist, I cannot pick up that, okay, these are inclusions inside the security system. Does not matter. What matters is you just need to pick up malabsorption syndrome in adult. Two differentials. Either it is tropical sprue, it is Whipple's disease. If it's gonna incorporate CNS or CVS manifestations, you know the diagnosis of the patient. In fact, we can also do a PCR, no? I mean, one more technique that I can use for identification of this condition is also PCR, but then the cost factor can definitely come in that case also. Some related terminologies that I would like to highlight is one is Whipple's triad. I have discussed this in the topic of insulinoma with pancreatic neuroendocrine tumors. Second is Whipple's operation. You know that from surgery, that would be related to cancer of the head of the pancreas. So there are three terms that begin with the word Whipple: Whipple's disease, Whipple's triad, and then Whipple's operation that I've just highlighted before you. And next I'll explain to you bacterial overgrowth syndrome. This topic is relatively less studied because it's towards the end of the discussion, but we need to keep the focus on. And right at the onset of describing the topic, I want to tell you that the investigational choice for this condition is not small intestinal mucosal biopsy. While I speak, I'll give you some time to think what could be the investigational choice for this condition, but it is not a small intestinal mucosal biopsy, as is the answer for most of the cases of malabsorption syndrome. Let us try to understand what is the problem in this case. You see, I'm just trying to represent here the cecum. I have shown the appendix, then I have shown the ileum. You see, at the junction of the ileum and the cecum would be the ileocolic sphincter. This ileocolic sphincter works as a one-way valve. It will always allow food from the small intestine, that is the ileum, to go into the cecum, but it will not allow any contents of the cecum to come back into the small intestine. So the functional aspects of the sphincter are highly important because it will prevent the anaerobes. You see the count of anaerobes. When we look at the count of anaerobes in the large intestine, they are to the tune of 10 raised to power 11. When it comes to the bacteria in the ileum, they are something in the range of 10 is to 8, and as you start going towards the jejunum, the counts will progressively reduce. I mean, there are hardly any bacteria in the duodenum and in the proximal part of the jejunum, but then as we start going distally, the counts will start rising. You need to remember two values at the moment: the bacterial count in the cecum and ascending colon, and it will keep on increasing subsequently, is 10 raised to power 11, and there are relatively lesser number of bacteria present in the terminal part of the ileum. Now, if God forbid the ileocolic sphincter malfunctions, I'm just saying malfunction by just a hashtag here. If the ileocolic sphincter will malfunction, then the functionality of this is hampered. So this can allow the bacteria of the large intestine to come into the small intestine, and once the counts will increase, the local mucosal damage can be seen. When you read the term bacterial overgrowth syndrome, I want you to appreciate the fact that it's not that the bacteria start growing just by that or just like that. It is rather a damage to the integrity of the ileocolic sphincter. Now, why can that happen? It could be due to TB, it could be due to Crohn's disease, because Crohn's disease involves the terminal ileum, or rather common in India, typhoid can, if typhoid also involves the ileum, and if the ulcer of typhoid involves the sphincter also, so the functionality of the sphincter would be hampered. So any of these causes which are relatively, when I say typhoid per se, in poor socioeconomic status in India would be commoner. So all of these conditions can damage ileocolic sphincter, and in some cases, the damage may not be demonstrated also. It is just that this sphincter does not work properly. So it could even be idiopathic occurring in a person. The bottom line is that you are gonna be having large gut flora. Mark my words there. Large intestinal bacteria are migrating into the small intestine and are causing mucosal damage. The end result would be a B12 malabsorption. One of the highlights of this condition is, apart from mucosal disease of the terminal ileum, which will contribute to nutrients being malabsorbed, B12 deficiency will definitely be a feature of this condition, because that's the primary site of absorption of B12. Now let us look at what will happen to folic acid levels in this condition. And surprisingly, when I was a student your age, in the books it used to be written folic acid levels are elevated in bacterial overgrowth syndrome, and there was no explanation given in standard books. So we used to be very surprised and discuss with my friends, I used to talk about, why is folic acid elevated here? It should also be reduced. And that's the same query that I get even today after so many years from young doctors in final year who are asking me, sir, why is folic acid elevated? After all, you were saying a mucosal disease. A mucosal disease is in the ileum. Mucosal disease should be present even in the jejunum, because bacteria are going retrograde. So there should be decrease of folic acid level, but it is elevated, no? So I want to tell you that why is this folic acid level elevated is because you see folic acid in this condition is being produced in excess by bacteria. The point is because the bacterial count is increased in the proximal part of the gut, that is the small bowel. So bacterial metabolism, that is what is description given in the gastroenterology books. They say the bacterial metabolism produces folate compounds, and these folate compounds tend to increase the folic acid level. So this is a very good pointer towards the diagnosis of this condition, because traditional thought process would be that if jejunum is damaged or ileum is damaged, then jejunum should also be involved because the infection is going retrogradely. So logically speaking, if I just go by logic, then B12 and folic acid both should be lesser. But that is not the case here. No? Folic acid is elevated because that's the end product of bacterial metabolism that is generated in very large amounts in this case, because of which the folic acid levels would be highly elevated. And apart from this, standard features of malabsorption syndrome in the form of osmotic diarrhea can be given because mucosal disease is anywhere. Since mucosal disease is present, he will write the words like he can say breath hydrogen test is defective, or he can rather say D-xylose absorption test is defective in this case. So I want to highlight, if you read a question in which D-xylose absorption test is also defective and simultaneously B12 levels, that is Schilling's test or any other test for B12 deficiency, both are demonstrated together, you need to demonstrate, or you need to be first thinking in terms of bacterial overgrowth syndrome, also called as SIBO, that is small intestinal bacterial overgrowth. To confirm the diagnosis of this condition, the best way would be to go in for jejunal aspiratin culture. Now, this is what examiners would like to hear from you, because they know the thought process of any doctor would be that for any malabsorption, the answer is small intestinal mucosal biopsy. But I think I've given you substantial lag period to come to the diagnosis of this condition. Jejunal aspiratin culture is the best way by which you can demonstrate, and now the culture will be showing more than 10 raised to power 11 organisms per ml of the jejunal aspirate that has been taken out. Traditionally, this count should be present in the large bubble. So the point is, large bubble counts in the small bubble is what is called as bacterial overgrowth syndrome. Other tests that can be used for diagnosis can be breath hydrogen test. I hope you recall that's because to test for carbohydrate malabsorption. We can go in for breath triolein test. He can either describe the symptoms, the traditional ones that are spoken multiple times, or he can write these tests also that can help you in identification. As I said, abnormal Schilling's test. Combination of abnormal Schilling's test with elevated folate levels and malabsorption syndrome manifestations given is a diagnosis or a shortcut that can be used for identification of this condition. The treatment will be metronidazole because I want to get rid of the anaerobes. Here I also want to bring in an anatomical aspect here. One student just sent me a image-based question actually, and he said that he had this exam in which there was an arrow at where the appendix, you can see this, I'm just putting a small a, appendix is meeting with the cecum. So the question was anatomical, obviously. He was said, what is the name of this valve? So what I've shown subsequently in red color is the ileocecal valve, but this valve at the junction of the cecum and the appendix is called as valve of Gerlach. This is just an accessory fact that I thought I'll just share with you because you see young doctors like you keep on sending me queries. So as they keep on sending me queries, I think that I should just share with everybody. So that was just a small effort there of an additional point being mentioned. Otherwise, the primary focus for manifestations of this patient will begin by describing an adult having abdominal distension, and then he will talk about bloating after eating food, borboigamy developing in this person, weight loss occurring, and sometimes, not always, he might even say the word bile acid diarrhea. Well, you are aware of the fact that when it comes to metabolism of bile acids, then bile acids are again assimilated in the terminal ileum, and if the terminal ileum mucosa is hampered, then the bile acid metabolism part is also distorted. So bile acid diarrhea is a feature that can be seen with bacterial overgrowth syndrome. I will now describe a question to you that begin by describing a person having a abnormal Schilling's test, though I have already told you this test may not be routinely available, at least in routine laboratories. The question then said that the test is becoming normalized, so there is a normalization with metronidazole. Now, how did that happen was because metronidazole killed those excessive anaerobes and the normalcy was obtained, and the end result was normalization of Schilling's test. The disease that we are talking about is what we just discussed few seconds ago, that is bacterial overgrowth syndrome or small intestinal bacterial overgrowth. Let me write this again so that you can be more sensitized to this. Suppose you get a question in the exam that says person is having abnormal Schilling's test, and then there is a normalization occurring, but this is occurring with pancreatic enzyme supplementation. This means the fact that this person was suffering from chronic pancreatitis, because if there is a pancreatic enzyme deficiency, even then B12 is not absorbed. One of the reasons for B12 malabsorption is going to be intrinsic factor deficiency, another can be pancreatic enzyme deficiency, and thirdly can be bacterial overgrowth syndrome. If pancreatic enzyme supplementation is causing normalization of this Schilling's test, therefore the diagnosis of the person would be given as chronic pancreatitis, which can obviously be confirmed by doing a CT abdomen in this person. If you get a question that says abnormal Schilling's test is present in a person and there is a normalization occurring, but this normalization is occurring with rather intrinsic factor supplementation, then you know that the diagnosis is type A gastritis. I've just tried to highlight here 3 standard questions which have been asked in the exam. The concept is that he mentioned abnormal and a normal Schilling's test. In between the two, there was some intervention done. The intervention was one in the form of administration of metronidazole, second time a pancreatic enzyme, third time an intrinsic factor, and therefore he said what is the probable diagnosis of the patient. So if you just highlight on the 3 terminologies on the extreme right hand side, you can understand why there's a normalization, because you're treating the problem of the person. I mean, you are killing up the anaerobes, you're giving a pancreatic enzyme supplementation. That is why there's a normalization occurring in this case. So I'll now quickly summarize regarding the investigations that you have been taught for the following disorders. For celiac flu, the main test to be done is a small intestinal mucosal biopsy. Well, it has to be repeated 2 times before and after, and you can demonstrate the flattening versus the regeneration component. And therefore you are spot on in your diagnosis. And if he gives you regarding anti-TTG or anti-gliadin antibody or anti-endomyosil, that's anyway a welcome bonus. For Whippers disease, I have highlighted again a small intestinal mucosal biopsy with the mention of past positive inclusions, which are those nasty bacteria sitting inside the security system, that is macrophages. For small intestinal bacterial overgrowth syndrome, however, the investigation that is recommended would be a jejunal aspirate and a culture. The culture report will be showing high counts in the small bowel. That would be to the tune of 10 raised to power 11 organisms per ml. I mean, traditionally the counts here are in the range of 10 raised to power 8. I did not write tropical sprue here because you see, for tropical sprue, even if you do not do a small intestinal mucosal biopsy, tab bhi chalega. That's because you need to demonstrate 2 products malabsorption either with help of breath hydrogen, breath toluene test with history of traveling to a developing country, or for Indian patient like a person eating out street food and having recurrent episodes of diarrhea. If you demonstrate what I just said, 2 products malabsorption, it's a diagnosis. So small intestinal mucosal biopsy is not mandatory to be done in cases of tropical sprue. I also want to highlight that I have explained to you regarding D-xylose test, which is gonna be telling you regarding problems of the mucosa of the gut being hampered. And for Schilling's test, obviously it is B12 deficiency because ileum is hampered. Now I wanna talk about combinations here. The combination I mean is, like, suppose you get a question which says D-xylose testis absorption is defective. That means that there is gonna be mucosal disease, and he says Schilling's test is also abnormal. So if you are having 2 abnormal simultaneously, you see, if you look at the second entry in this table, bacterial overgrowth syndrome, it is both a mucosal disease as well as the Schilling's test will also be abnormal. It will become normal after antibiotics. That is a separate issue. What I'm saying is, if you get a question in which both reports are given to be abnormal, you have to think in terms of bacterial overgrowth syndrome. On the other hand, suppose, let's take up case of celiac sprue. Celiac sprue is only a mucosal disease. Now, in that, right in the beginning, I said ileum is usually not involved or is minimally involved, that we don't get a B12 deficiency. That is why if you see the report here, it is written celiac sprue D-xylose is absorption is decreased, but Schilling's test is normal, because I highlight once again that ileum is usually not affected. The message is that there will be only one MCQ where you will have to answer a particular term where both D-xylose absorption test will be normal, Schilling's test will be normal, and still there is a malabsorption. Well, the condition that I'm teaching you towards the end, so keep the focus on, is called as intestinal lymphangiectasia. Well, as you can read from the word lymphangiectasia, it means malformation of the lymphatic channels in the gut. You are aware of the fact that fat is gonna be absorbed from the gut in the form of chylomicrons, and then it is transmitted via the lymphatic system before it travels into the thoracic duct and then goes into the venous circulation. The message is in lymphangiectasia, there is abnormal development, or there is rather no communication. These are abnormal lymphatic channels which are not communicating with ultimately the main thoracic duct. As a result of it, fat will not be absorbed, and therefore the question will begin by describing features of steatorrhea in this person. So the hints that I want you to remember is, if a question begins by describing mainly steatorrhea manifestations, says the fact that Schilling's test is normal, he also says D-xylose test is also normal, you will be in a fix, because traditionally our thought process is, because we are studying this topic malabsorption, we anticipate that these two tests, either of these two should be abnormal. But if a question describes both of them to be normal, you need to think in terms of this particular disorder, intestinal lymphangiectasia. Well, how this disease will be diagnosed? Obviously a biopsy, because a biopsy will be demonstrating dilated lymphatics. So you saw here that tropical screw, even if you don't do a biopsy chalega, but you need to do a biopsy for intestinal lymphangiectasia, because otherwise how do you demonstrate the malformation? The final summary here is, for malabsorption, usually the tests like D-xylose Schilling's are abnormal. The only MCQ of malabsorption where both of these tests are given to be normal and still there is steatorrhea manifestations is intestinal lymphangiectasia. These are the details that I want you to remember for this topic. Keep learning, guys. Keep hammering on a regular basis. Keep on learning these micro topics, subtopics on a regular basis. You keep on upgrading yourself. That is the strength that you will develop.